Good morning or good afternoon, depending on where you're joining us from, and welcome to the SCIP Virtual Event Series. And thank you so much for joining us. It's my pleasure to welcome you to today's program, The Analytics of COVID-19. For those of you that don't know me, my name is Michelle Winter, and I'm the Director of Education Programming here at SCIP, and I'll be moderating the program today. I just want to go through some simple guidelines to make sure that your experience during the program is maximized. First and foremost, this is a live webinar and your computer will show the presentation and stream the live audio, so please ensure that your computer audio is on. All participants will be muted during the duration of the program. There is a Q&A function that will be active during the presentation that enables you to type your questions in for the moderator, me. We will get to as many questions as time permits, and those we don't get to will be addressed at a later date. In other words, we'll send these over to our facilitator, ask him to reply to them, and send them out to all attendees. Last but not least, we don't foresee technical issues. However, sometimes internet programs are subject to them. And should this happen, we will contact you regarding rescheduling. SCIP is thrilled to have Steve Roemerman, the Chairman and CEO of Lone Star Analysis, as our facilitator today. With that, Steve, the floor is yours.
Thanks, Michelle. What I'd like to do today is to take you through a thought process that begins with what we call the 3 C's of analytics and talk about the uncertainty around COVID-19. I'd like to talk a little bit about how we humans process uncertainty. And then we'll go into more of the hardcore analytics, and it will end with a look at how Americans are feeling. We've been doing some public opinion polling, and we'll share that with you. So what are the 3 C's of analytics? Well, those are capacity, competence, and candor. Do we have the capacity to get data that has quality? Do we have the competence in the information chain to deliver it? And does everybody want to be candid? Those are the 3 questions that usually it's a good idea to ask when you do analytics. And when we ask those 3 questions for COVID-19, the answers are not encouraging. We don't have the ability to test everybody. The tests that are being done have either false positive or false negative rates. And those rates are very hard to nail down because they change with the virus load in the patient that we're testing. We don't have standardized protocols for testing and reporting. Those are different in nearly every jurisdiction. So who gets a test? How far along do they have to have? What test am I doing? Is the test optimized to create positives or negatives? And then the officials who are being asked to process all this information are being asked to do things they haven't been trained for, so it's understandable they can't really understand. And then finally, with candor, it's very hard to expect people under stress to be truthful with themselves, and then there are people who have motivations to not be truthful with us. So when we ask the 3 C's, we really began to realize that we're facing a substantial amount of uncertainty. So let's talk about how that uncertainty looks like in a quantitative sense. Imagine that I've got a hypothetical country and I'm going to try to test about 30 out of every 1,000 people. And the reality, although I don't know it, in this population is I have 12 infected folks. The testing has been optimized to detect the disease, which means I'm going to have a high false positive rate, but I also have a false negative rate of 30. I'm going to test 30 people, and I've tried to target folks who are likely to be infected. And so of the 12 people who are infected, I actually get 10 of them. Now, when you run that out, here's what's going to happen. And this, by the way, is very much like what we're seeing in Iceland. Iceland is the country that has done more testing per capita than anyone. We're going to see 14 folks who will show as positive. Of those, about half will be positive truthfully and half will be false positive. So I've got 7 false alarms. I'm going to fail to detect 5 of the 12, the 3 false negatives and the 2 that I didn't catch. So I'm going to actually screen about 58% of the folks will be detected correctly. So that's just to give you a sense. This is purely hypothetical. It's just to give you a sense of, with a new disease and new testing, we don't expect a lot of specificity. You can also see the problem. If I try to test 100% of the population, I'm going to generate a very large number of false positives. So when we asked the third C about candor, the headlines are full of both individuals and organizations who are not telling the truth. So we know we have a problem with candor, and that especially is a problem with respect to government organizations who we'd like to be able to rely on for different kinds of information. And in particular, totalitarian regimes seem to be clamping down on information that we really wish was accurate. I talked to an epidemiologist this weekend who said no responsible researcher is using data from China at this point in their work. And China is a problem because they've been acting active disinformation and public relations campaign. I don't know if you have seen the video, but if you go to YouTube and just video, I am not a virus, or Italian China protester, you'll see a video like this. This was generated by China's state-run news agency. And if you collect up the stories on China, what you'll see is a number of really serious allegations that are on the chart there. I won't read it to you, but there's just a really severe prejudice against trusting Chinese data because, you know, it probably is true that we should avoid trusting it. So both the virus and uncertainty really seem to originate from the same place. I had a mentor a long time ago who told me that I should not try to tell the difference between lack of intelligence and lack of integrity. He said they manifest themselves in pretty much the same bizarre behaviors. So trying to untangle those 3 C's we just looked at, for which is candor versus competence, really is not our problem. The problem that we have is that we must deal with a great deal of uncertainty as we face COVID-19. And that's really the heart of the problem when we get to how normal humans process uncertainty, because we do this badly. There are a number of pretty interesting tests in psychology where we present usually grad students with logic puzzles where there's uncertainty. We give the grad students a candy bar. We present pigeons with the same problem. We give the pigeons bird seed. The pigeons will outperform the grad students pretty consistently because pigeons are wired to deal with uncertainty and we're not. This takes us to prospect theory. And Daniel Kahneman and Amos Tversky show that we're really bad at uncertainty. And in particular, we're bad when we face the risk of loss. So the risk of loss is what we face when we think about losing our health, when we think about losing our lives, and when we think about losing economic well-being because of the contagion. Pretty common to see people outspend 10 to 1 when they're trying to do loss avoidance. The technical term for this is loss aversion. So we know we face uncertainty. We know that human beings are going to be irrational as they face it. So in Texas, there's a town for that. There's a town called Uncertain Texas. There are people who live there. And part of what I want to talk to you today is how do you live in the face of uncertainty? Because you can do that. There are people living in Uncertain Texas right now. It's a very nice little town. And the way epidemiologists start out with understanding contagion really begins with statistics and simulations. And usually we do this after the fact because the early data from epidemics is always wrong. That's why we shouldn't be surprised about the uncertainty that we've got right now. What we typically try to do after the fact is fit statistical data the best we can into information. Now in the 21st century, what you've seen is a move towards simulation to make sense of epidemics and also to create policy about what to do with them. And this is really the first big epidemic where we've seen simulations try to be used. And we shouldn't be surprised that our first attempt as a society to make sense of a problem using this kind of simulation, that as a world, we are inconsistent in how well we're doing with these things. So let's talk about what's in these simulations and how people think about them. The core concept is called the reproduction ratio, and the initial reproduction ratio is called R0. And the reproduction ratio changes as the epidemic proceeds. If that reproduction ratio drops below 1, the epidemic dies out. And what reproduction ratio means is I have someone infected, they're exposed to other people that are shown by these solid arrows, and of the people who are exposed, some number catch the disease. In this case, 2 folks have become infected. That gives us a reproduction ratio of 2, 1 person infected 2 others. Now, if that reproduction ratio was bigger, then we'd expect more of these folks to be infected. And we might see these people who were in the proximity but not fully exposed, we might see them infected too. So the idea of exposure versus proximity is a subtle thing. Now what happens is we get to a second generation, this person eventually becomes contagious, and well, they're exposed to another first generation patient. Well, that person now has immunity. So what we see is, as the epidemic progresses, the number of unexposed people decreases, or another way to say it is what's called herd immunity increases. And so to really do this kind of math, you have to use differential calculus. The problem is that all these numbers are uncertainty, and most people don't do good simulation work with stochastic differential calculus. In other words, differential calculus that takes uncertainty into account. The other thing that we need to understand if we're going to try to do epidemic math is what's called a non-pharmaceutical intervention. And non-pharmaceutical intervention is what we're experiencing in Western society right now. That's social distancing, and in particular paid time off. It's quarantining people who we believe or suspect to be infected. It's hand washing, and it's banishment. Now, in the old days, we used to have an island that we banished people to. Now we have school closings. The 21st century equivalent of banishment is to forbid people to go to certain places, to shut down certain kinds of institutions. A third concept for the math is what we call pharmaceutical interventions, and those would include treatments like antivirals, preventions like vaccines, or antiviral prophylaxis. But those really have not come to bear yet. There is hope that we will have some of these before long, but for our purposes right now, we really don't have enough of this to know that we can rely on it. So this concept of the reproduction ratio, or R0, how important is that? Well, I told you we really need to do differential equations. If we don't do differential equations, we just ignore the fact that there are immune people. This is 330 million people, roughly the population of the United States. And if R0 is below 1, the epidemic dies out pretty quickly. And you can see that fairly small changes in that number will change dramatically how the progression of the epidemic will play out. We do peer review. We normally don't do these kind of analytics at Lone Star. We occasionally do peer review for other folks. People who do this kind of work will typically guess the initial R0 somewhere in this neighborhood. There are a bunch of good reasons why those are usually good initial estimates. And then as data comes in, they'll adjust their estimate. So that early estimate is very, very tricky. Here's two cases. One is an R0 of 2 with 1,000 people who come into the population infected initially. And here's an R0 of 1.7 with 10,000 people who come in. And while what you saw before was a very different look on that chart, here these two lines look really very similar, and they don't diverge for quite a while because of that factor of 10 change of the initial infected population. So we don't know the initial infected population, so you can see that it's going to be difficult to estimate what the reproduction ratio is as a result of our lack of knowledge. So the obvious question is, do we know the reproduction ratio for COVID-19? And the answer is, of course not. Really serious researchers who look at this from the 1918 Spanish flu epidemic will argue about the value of R0 from that time. We also know that R0 is going to vary by community. If we look at the Ebola epidemics, we know that the reproduction ratio varied really even in neighboring countries because of a variety of different things. If we take a look at COVID-19, we're going to see that the R0 varies quite a bit. The estimate of what happened on the Diamond Princess cruise ship was a reproduction ratio about 4 times higher than what we think probably happened in Wuhan. The lowest kind of credible R0 is one of the early cases in Washington State, where a lady was exposed to 312 people, and only her husband ended up testing positive. So we think this is probably a virus where close proximity matters, but it's dangerous to take one case or one narrative and believe too much by that. If you take what we think are credible, most of the estimates are between 1.5 and 4, and the most credible estimates are around 2.3. There are right now substantially more than 1,000 papers on COVID that are in various stages of peer review, and those will eventually be sorted out. But for right now, we really have a statistical span of uncertainty. Now, we used a tool from Lone Star called True Navigator that allows us to create what amounts to a random variable. And this is the distribution of reproduction ratio uncertainty for COVID-19 that comes from the papers that we've read. And you see this distribution that sort of peaks here around 2.3. The tail goes out to 7, which is about the biggest number anybody really kind of credibly claims, and it dies on the other side at about 1.5. So that's what we think the uncertainty of COVID-19 looks like. So we said there's 2 things we need to talk about. We need to talk about reproduction ratio, and we need to talk about the effectiveness of intervention. And after the epidemics of the first part of the century, there was some good work funded by the National Health Service in the UK and NIH in the US. And these 3 institutions built models. You're reading a fair amount about the Imperial College model right now. People are using that to try to do policy work. And we know that in all epidemics, there are some things that work. So we know sort of isolation is going to work. We know sanitation is going to work. What we don't know is compliance rates. And one of the things that are typically treated as important variables by serious people who do this work is, what do we think the reproduction ratio is? And then how well will interventions work? And in particular, will people comply? And we have measured data from the past. And we know some things about how viral epidemics proceed versus bacterial epidemics. We know some things about coronaviruses. They don't like soap. They don't like being too wet. And we don't know at what temperature COVID really begins to die out, but we know that COVID viruses in general don't like to be warm. So there are some things that we know, and if we take the work from the 3 colleges that I talked about, their 3 simulations, and you just look at how much reduction we get, you see a median reduction of about 15 to 1 if I can get reasonable compliance. And even fairly low compliance will get me reductions of 4, 5, or 8. The best estimate from Diamond Princess was that they had a reduction in the reproduction in the reproduction ratio by about a factor of 8 when they began to lock the ship down. So if we can get a reasonable level of compliance, then reproduction ratio is going to be hit pretty hard. And if you look at what's going on in North America right now, we have a fairly substantial compliance. Schools are shut down, many businesses are shut down. When we take those two statistical distributions and blend them together, then we can get the probability distribution of reproduction with interventions. And it looks like it's pretty unlikely that the reproduction ratio is above 1/2. And there's different ways, different societies are trying to dampen this out. In Iceland, they're using testing, and they believe that they will end up with something around less than 0.5% of the country will be exposed, and only a percentage of that will end up, well, I'm sorry, will be infected. Less than 0.5% will be infected. A pretty small number will end up in the hospital, and they have the hospital capacity to handle that. So different societies are handling this differently. A small country like Iceland, where they can do a lot of testing, is going to be different than a poorer country, say, that of the same size as Iceland, that didn't have that. So just to remind you, we went through a whole bunch of that. What the R0, if it's below 1.7, and 99% of the cases on that prior chart were below 1.7, you see this kind of progression as opposed to this kind of progression with no intervention. So intervention is extremely effective, and we're in a period of pretty robust interventions. And what we hope is that we're going to see not a lot of progression. So one of the things that we'd like to do is compare that with other epidemics. A way to do that is to think about the median without intervention, a high estimate of the reproduction ratio, and a low estimate with intervention. And the key question is, how many nations are going to be able to knock COVID-19 down into this small number that's less than 1? And there are good reasons to wonder about that. I mean, if we think about the flu, and you think about how many of your colleagues choose to not get a vaccine, people who come to work sick are required or feel like they have to. So we rarely see the kind of reproduction ratios that we think we're probably getting with COVID-19, because we don't ask people to limit their behavior, and people don't comply when they do. The question is COVID-19 different? And I think most people would say it probably is in the United States. And will it be different in other countries? I think we have to be a little more skeptical about, as we go around the world in different cultures, how many people will actually do this kind of compliance. Now, I want you to look at this chart for a minute. Among epidemiologists, measles is sort of the boogeyman. Measles has a reproduction ratio of about 15. And even when you jump on it pretty hard, it's hard to knock measles down below 10. So measles is the boogeyman as far as reproduction ratio goes. And some of the recent epidemics we've had, here's SARS, here's H1N1. You see there's a wide variety, and here's Spanish flu. I told you we still don't know what the reproduction ratio was for 1918 Spanish flu. So this is just to give you a sense of what we think COVID-19 is compared to these other epidemics. Now, the other question people want to ask is, well, that's all fine, but if I catch it, will I die? And estimating mortality rate is very tricky. If you look at the way epidemics progress, early mortality rates are usually estimated too high. There's a number of reasons for that. The other thing to know is that lab confirmed mortality is nearly always different than the actual death toll, and lab confirmation of the virus is not the same thing as cause of death, except maybe in Italy. If you look at the way statistics are taken in different countries, if someone, say, dies in an emergency room with cardiac arrest and they were in pulmonary distress, in some countries that death is going to be coded as a heart attack. In Italy, it's probably going to be coded as a COVID-19 death. So reasonable people can differ about what is the cause of death. If you look at the United States, we have about 60,000 deaths a year that most people would attribute to cold and flu. Many of those are really hard to attribute. We go back to all these other confounding variables that people have and different ways that people are sick. The early deaths in an epidemic are almost always out of the vulnerable populations. And if you get a really bad cold that goes through a nursing home, you can see 8% mortality from the common cold. So these untreated and poorly treated hotspots are where we typically see early death. When we begin to project those out into the rest of the population, we're trying to extrapolate noisy data. It's very difficult. But there's been some pretty good work done that, in the United States with our healthcare system, if we don't saturate our emergency rooms, the death rate is between 1 in 2,000 and 1 in 170, or a 20th% to about 0.6%. So no, most people who get this are not going to die, but some people will die from this and are dying now. So far, comparatively, the number of deaths are low. This chart cuts off on March 17th because that's about the last time the China data seemed to be semi-credible. It's not clear they've been telling the truth since then. But at that point, the total number of COVID-19 deaths were less than flu deaths in just the US. And that's probably still true a week later. But Italy shows us what happens when things go bad. This curve from Italy, which has since passed the China mortality curve, tells us what happens when I've got ineffective interventions or when my hospitals and healthcare system get overwhelmed. But overall, nations that manage well should see fairly moderate death rates. So Singapore is an example. America could be an example if we maintain some sort of sanity. And one reason for optimism in the United States is we have a lot more ICUs per million than most nations. We have about 250 ICUs per million, and we have the ability to expand rooms with ICU-like capability of ventilators to a higher number than that. But the thing to remember is these non-pharmaceutical interventions all cause economic impact. And the question is, from a loss aversion standpoint, are we spending $10 to avoid losing $1? So that's really the question, I think, in the United States. In the other nations, without management, without health care, we have to suspect that they will suffer. And the question is, well, will we see 2 million cases worldwide, 7 million cases worldwide, 50 million? Because that could create a persistent virus pool that creates an ongoing problem for the United States, creates ongoing challenges for businesses that rely on international travel. So I've tried to walk you through fairly quickly what we can say analytically. What I'd like to do now is talk a little bit about how people are reacting and how we might think about that. The first poll that we did was run on Monday the 16th. We got about 200 respondents. We took a snapshot at close of business that day when we had 167 respondents. That's the data I'm going to show you. We asked 5 questions, and the average response took less than a minute. So this is a low cognitive load. We are trying to excite what Daniel Kahneman calls system 1. We're not asking people to think. We're asking how they react. And largely that's important because people are reacting right now. Many people are not actually thinking as much as we might wish or hope. So the first question we asked is, what's your impression on whether COVID-19 is easy or hard? And we showed you what the contagion rates are likely to be. And while this is not a quantitative measure, this suggests that people are probably overestimating the contagion risk. And maybe that's not bad because it seems to make people more likely to observe non-pharmaceutical interventions. The second question we asked is, compared to other illnesses you've heard about, like the flu or measles, how would you rate COVID-19 in terms of being a severe illness? And the reason we ask those questions is those feel familiar to people, but in fact, measles is a really bad disease. In Africa, where they don't do measles vaccinations, you see about 25% of the people who have measles end up with long-term effects like vision damage. So these are both pretty bad diseases. Flu varies with the flu season. And what you see is that people see COVID-19 as being as bad or worse than familiar diseases, even though we really don't know. So again, the idea that this is a bad disease is probably going to make people more likely to obey the interventions that are being suggested to them. Now, the third question we asked was, I think, the most interesting, and that was how close is this to you personally? About 80% of the people don't feel connected to COVID-19 at all. But it's interesting, we had one person who said they had it, and a surprising number of people who said that they knew somebody who had it. A week ago when we ran this, and this was in the United States, these were all American respondents. There were 4,000 confirmed cases in the United States at that time. The odds that this little poll with 167 respondents got one of those 4,000 out of a population of 330 million is really, really tiny. And one of the things that you find when you do this kind of research is you have to ask yourself, well, what's more likely? I've got different levels of hypochondria in the United States. Typical, if I just take a typical random population, I'm going to have about 1% of the folks suffering from hypochondria. There are some cohorts where it's as much as 7%, and hypochondria is usually worse in the presence of fear. So when we say, well, did this respondent actually have COVID-19, and did these people actually know somebody who has it? And the answer is probably not. Probably this little wedge right here are folks who are expressing their hypochondria and fear. And I don't say that out of judgment. I say that in a really clinical sense. The last two questions we asked were concern about health and concern about economics. And if you say, are you concerned about the health and safety of yourself and your family? And how about economic impact to yourself and your family? One way to look at this is, here's the wedge of people who are extremely concerned, and you can see the green wedge is bigger economically than when I ask about health concerns. And if you just come around this wedge on concerned, that's a bigger number and it's a higher level of concern. So what we take away is that in the population in general, economic concerns are higher than health concerns. When we looked at the lowest paid respondents, what we saw was that they were even more concerned than the rest of the cohort. And even when we took the population from the previous chart, where people said they knew somebody about it or they knew somebody that was suspected, these didn't change. The lower paid you were, the more concerned you were about economics, regardless of whether you felt close to it or not. Now, those are really small numbers. The data may not mean very much because it's a small survey, but it's still suggestive. Now, we reran that survey a couple of days ago, and on question 1, when we asked how easy is it to catch, that's trending towards easier. People think that this is more contagious than they did the prior week. When we asked how severe, it's trending towards more severe. When we asked how close is it to you, we doubled the rate, actually tripled the rate of people who said they had it or were close to it. So the odds of actually having 2 polls have found 3 people who've been diagnosed, if you run those odds out, and the number of people who'd been tested at each point, it's about 1 in 2.3 million. So, I mean, we're really getting up to the kind of thing that it's more likely that we could be struck by lightning than that we would actually find these 3 people. So this really appears to be an indication of the level of fear that people have more than the indication of the level of the disease progressing through the population. Well, it's not a surprise then when you ask people, are you concerned about health? Now they're more concerned about their health than they were the prior week. But when we asked about economic impact, that has grown, and it's grown greater than the concern about health. And one of the things that I've never seen in polling was when we went to the cohort below 25,000 in the 3 and 20 data, 100% of them are now concerned. So very consistent that the less money you make, the more concerned you are. If you're a single mom and you work as a waitress and you're trying to live off tips and you're trying to figure out how to get diapers for today, you're very stressed out. So what we see is public sentiment moving towards a more dire and more fearful position, and that's especially true in the lower paid cohort. Now, we did a third poll that we just closed out, where we asked people to say how they would change when the crisis was over. And I don't think that you can read much into these responses, but we asked people what they were more likely to do and less likely to do. People want to go back to shopping in their neighborhood, but they also think that they're going to shop more online. People believe they will cook more at home than they used to. They're anxious to get back on airplanes and start flying again, and they miss casual dining. So these are pretty strong sentiments that tested out pretty strongly. There are some other things that are not as strong, but they all suggest people would like to get back to social activities. They want to go to malls. They want to go to their health club or to their pub. They want to see large entertainment venues reopen, and they want to get back into their community and worship settings. So these are all things that people suggest, they think at least, that they will want to do more of when they're allowed to. People are already tired of fast food delivery at their house. It's not clear that they want to go back to large professional conferences. It's interesting that they seem to be tired of online events like the one we're having at the moment. People don't seem to like working from home, and they don't seem to be too thrilled about low-price things from China, and they're not terribly interested in traveling outside the United States. The comparison of traveling outside the US versus inside the US for this American poll that we did, I think is a pretty interesting result. The outside the US result's not a very strong, it is less likely, it's statistically significant, although it's not terribly strong. But it's very different than the sentiment if I want to get back on the airplane and travel around the United States. The last question that we asked in the poll was how people saw China. And the question we asked was, do you agree or disagree with the following statement? I think China has been truthful and helpful in dealing with the coronavirus situation. It's a very odd distribution of responses. You've got 3 peaks. You have a peak here on agree. You have a peak here on I don't know. And you have a peak on strongly disagree. Now, if you add up all the levels of agreement and all the levels of disagreement, the negatives outweigh the positives. So broadly, what you see is the overall sentiment is disagree. But what's really interesting is the strong negatives, the strong disagrees are almost exactly twice the strongly agrees. So it's pretty clear that in spite of China's efforts to mute how people react, that people do sort of feel bad about China right now. So when you take the public opinion data, you come down to really, I think, 4 takeaways. One is the public seems to have made COVID a slightly bigger giant than it's likely to be, and that giant is still growing as of our last poll. So as I've said 3 or 4 times already, that does suggest that there's going to be compliance with the intervention guidelines. Economic concerns are really top of mind, and in particular for low-income households. And we shouldn't be surprised if low-income cohorts feel like they're forced between the intervention compliant and basic necessities. And if that happens, necessities will win out. They will go do something to make some money to feed their families. People don't expect to return to exactly normal. And while I don't think the polling we've done is really very prescriptive about how we're likely to see change, I think we ought to expect that both B2C and B2B are both going to change. And I think as time goes on, those changes will be clearer. And the last thing is, my take of that 3-peak distribution you just saw is that China's disinformation campaign is blunting the backlash they might otherwise face. But in spite of their efforts to manage their brand, the China brand is damaged. And it'll be interesting to see how that plays out over time. So in conclusion, what I like to do when I put together a presentation like this is I try to think about what I hope the audience will know, what I hope they will think, what I hope they will feel, and then finally do. So what I hope you know is that we face a lot of uncertainty around nearly every aspect of COVID-19. And any statement of absolutes is suspect. So when people make, absolute pronouncements, we really should be suspicious of that. We don't necessarily need to suspect their motives. Their motives might be pure, but we need to suspect the accuracy of their statement. We need to recognize that we human beings, all of us, are bad at uncertainty, and we're really bad about uncertain prospects of loss. That's one of our greatest weaknesses. We need to realize that the prospects that Americans are concerned about is not just their loss of health, but their loss of wealth. And our polling suggests that they're more concerned about their loss of wealth than their health. And that those economic concerns are increasing fastest among the poorest among us. Those are 4 pretty good takeaways that I think we can say we think we know those things. What I hope you will think is that, what irrationality is impacting my organization and my peers and me, because we're all at least a little irrational. But we live in the town called uncertain, and so we're going to have to make real decisions without perfect data. What I hope you will feel is that there's enough information to make some good decisions. And if we slow down and go from what Kahneman calls system 1 to system 2, and we actually think about it, there are going to be opportunities at every discontinuity, and what we need to be doing is looking for what those are. So what I hope you will do is to move past the panic, help other people to be prudent and not petrified, and to be positioned for what comes after COVID-19. So there's your know, think, feel, do. And with that, I'd be happy to take some questions, Michelle.
Steve, thank you very, very much. Folks, if you do have questions, please feel free to type them into the question box in your GoToMeeting. There's a little box on your screen. Lots of folks saying that this was an excellent presentation. Very, very great stuff. A lot of those. Questions. Here we go. Bear with me for just a quick second. Okay. What about the estimates that 40 to 70% of the world will get this virus?
Well, I think that we have to start with what data we have from previous epidemics. The best guess of 1918 epidemic, or what people call the Spanish flu, is 27% of the world population was eventually affected. There are some estimates that go as high as a third. I don't think any responsible researcher of that epidemic thinks that we got to 40%. We think about the Spanish flu. We were in the throes of World War I. We had thousands and thousands of young soldiers in hospitals who are already compromised because of gas attacks. They already had pulmonary weakness. We had people jammed into troop ships. We had none of the testing and medicine we have now. So if you ask yourself, well, is it likely that the things are as bad as they were in 1918? I think it's likely that they're not. So to get to 40%, I think, is a pretty interesting claim. And as a scientist, we're normally taught that extraordinary claims require extraordinary evidence. And we've gone off and tried to look at some of the papers that made those claims, and none of those that I've seen, maybe there are some and I haven't seen them, but none of those that I've seen have opened up their simulations to work. Now, there is a pretty good rule of thumb that if you have no interventions, that epidemics die out at 70% of the cohort having achieved immunity. So is there some work that suggests that, yeah, there's a theoretical way to get to 70%? Yeah, that happens, and you see papers on that. But for this, with the level of interventions we've got, if somebody has published a good paper that explains that in a way that's credible, I have not seen that.
Okay, thank you. Okay, another question. How did Lone Star choose sample to survey in the context of, quote, I know 5 of Dallas counties positively tested coronavirus victims. None have died, 2 have recovered. I don't know if that makes any sense.
Yeah, I think it does make sense. So the answer is that was a nationwide poll. It was a nationwide poll that was done with folks that had email addresses, and they were picked at random from a population of about 20 million people who had signed up to do surveys in exchange for donations to charity. There were some demographic controls to try to make that look roughly like the American population. The demographic controls weren't perfect, and certainly when you select folks who only have email addresses, then you're going to distort. Now, one of the things I think is interesting, I was talking to the director of a nonprofit organization that deals with poor people in central Dallas this morning, and what he pointed out was that among the poorest, they are the least digitally connected. So what that would suggest is if there is demographic distortion in our data, and I suspect there must be, then we are probably understating the impact of COVID-19 to poor people.
Okay. Question, where does your doubt for Italy's data on cause of death come from?
There's been some good reporting done, and in fact, I talked this weekend to an epidemiologist that is doing peer reviews of papers. And one of the things you have to ask when you look at data from each country is, well, how do they count? And there have been a number of pretty good stories that have been published, and so it's out there in a number of places. I think one of the ways that you see a big difference between Italy that people don't understand, one of the things that's a surprise among epidemiologists is Germany versus Italy. So if you had asked epidemiologists before the outbreak which of those two populations is the most vulnerable, all of the normal risk markers suggest the Germans. The Germans have a less healthy lifestyle. They've got higher body mass indexes. They have higher rates of almost every risk indicator, including smoking. So even though we think of Italy as a society that still smokes, the Germans are worse. And yet, in spite of all those risks, the Italians are reporting a much higher death rate, and some of that we think is socially related. COVID-19 seems to be spread by very close proximity, so family clusters, and there are more multi-generational families in Italy than there are in Germany, so that's suggestive. It's too early to say that that's a fact, but that's suggestive. But the other one is the Italians pretty clearly count differently than say the Germans do.
Okay. So to that point, we do have a question. Do you know of any other additional data from Europe regarding this type of survey or anything like that?
So the data there are a bunch of data sets out there, and there are several on the web. The one that I think is the most authoritative is the Johns Hopkins University data set. They seem to be doing the best job of validating the data that they load. They don't load the fastest. They may run a few hours behind some of the others. Some researchers that I've been paying attention to have stopped using the World Health Organization because of these problems with counting. WHO is a semi-political organization. So if they try to adjust data that somebody reports, that can be seen as a political act as opposed to an attempt to do science. So I think the Johns Hopkins site is the one that I think is the best. There are some others that are not bad. They have a number of biases built into them, and again, when you expect bias at this point in an epidemic, it's just the result of people having to make choices about how they report things. You can't not have bias in your data at this point. You only get to choose which mistakes you're going to make.
Okay. How do we weigh the increasing economic impact from overwhelmed medical resources, not only for senior or medically vulnerable population, but even for routine healthcare maintenance?
Well, I think that's a really important public policy question. Certainly what you see in many parts of the United States are anything that is quote unquote elective is being deferred because of wanting to make sure we have healthcare capacity. Right now, I think a lot of hospitals are pretty empty in anticipation of a peak that's coming. So most parts of the country are not overwhelmed at the moment, although there are some places where the healthcare system is in trouble. And I think from a public policy perspective, it's really difficult. It also goes to the United States is a big, diverse place. So what is really wise public policy, say in Manhattan, might not be very good public policy in Ward County, Texas, which I suspect most of the audience has never heard of.
Okay. Do you have any recommendations for business owners to assist their customers into making more prudent decisions as opposed to emotional reaction?
Well, I think that's a great question. And I think, first of all, we have to be sensitive to the reality that people are scared. And it usually doesn't help to tell somebody you shouldn't be scared. That does not help. That's not what people want to hear when they're frightened. What can help some people is to take them through a process where you move them from Kahneman system 1, where we're reacting out of instinct, to system 2, where we actually think about it. And so asking questions like, what will we do on the other side of this? How do we make it better for the people that we serve? And asking those questions in a way that helps people slow down and think a little bit is pretty good broad advice, I think. That's not original with me, by the way. I've heard other people say that, and I think that is good advice. I think when you go beyond that broad general advice, I think it really varies with settings. So the kind of advice that I might give to somebody who owns a movie theater would be which is very hard. That would be different, say, than somebody who ran the distribution of medical devices and supplies. So I think it varies a lot with the industry you're in.
Okay. Okay, let's see here. The questions are coming in fast and furious, Steve. Let me just get to this. Okay. Why the strict global implementation of NPI for COVID-19 when compared to other pandemics that were actually worse, i.e. with the higher RO and mortality rates? Do you have any theories about that?
The short answer is I don't know. I think that there was a lot of thought given after H1N1 and Ebola to what should we do. There was the money spent on the simulation work that I showed you by the National Health Service in the UK and National Institute of Health in the United States, and that work was intended to help people make informed policy decisions. I think that there are a couple of problems as a simulation guy, as a modeling and simulation guy. I think there are a couple of problems with those tool sets. One is they require you to make deterministic choices. They require you to assume that you know the reproduction ratio when you don't. So instead of treating reproduction ratio as a statistical uncertainty, you have to guess. And when you're forced to guess, and when you go through these things, you've got to make about 5 different guesses. Well, what feels like you're being prudent is, well, I need to guess on the safe side. So I guess high on reproduction ratio. I guess low on, how well will people respond to interventions. Well, if you make all of those guesses on the safe side, the odds that you are going to guess right now are close to 0. If you do 1 out of 10 times 1 out of 10 times 1 out of 10, you get 1 out of 1,000. You add another one, it's 1 out of 10,000. Add another one, it's 1 out of 100,000. So I think the use of these simulations is new in public health policy, and the nature of the simulations is probably not as helpful as we might wish they would be. I think another problem is that there are on the internet any number of slapdash simulations that you can run, and they're being put in the face of public policy decision makers, and they don't have any way to know that a really nice user interface does not equate to sound science behind the simulation.
Okay. How do you see, this is going to be our last question, folks. How do you see the vast shortage of test kits impact the real data for infections and in the modeling?
Well, I think that's a problem, and there are a couple of ways you can do that. One of the things you can look at is the data that you do have. So you have to start, anytime you don't have data, you have to start with the data that you do have. One way to look at it is the number of fatalities in the United States compared to the number of testing, and that I haven't looked at that in the last couple of days, but that number had been trending to not that different than the rest of the world, at least until recently, because we shut down our borders. We didn't have the big caseload of initial infections that a lot of other countries had. So while it's true that not everybody who wants a test can get one, it's not clear to me how far behind we were on tests that were actually clinically indicated. I'm sure we were behind, I just don't know how much. I think we'll know a lot more about that by the end of this week, because it looks to me that we are catching up on testing pretty fast. And I think we'll know more by the end of the week. But I think right now, that's about the best you can say.
Okay. And folks, that is our last question. Steve, I'd like to thank you very, very much for presenting to our membership and our audience. It's extremely knowledgeable, a valuable presentation, and full of really great like visuals and stuff, easy to understand what you were saying. We do appreciate that. Folks, for all of you that are attending, I will be sending out, Steve has generously offered to share the deck. I will get that out to you in the next next couple of hours. And again, Steve, thank you so much. And I hope you have, the rest of you have a great day.
Thank you.